My name is David Mankoff. I'm from the University of Pennsylvania, and I am a nuclear medicine molecular imaging as a physician and a breast cancer researcher, as well as a Komen Scholar. I've got to start by saying, as a molecular imager, I'm so proud to have a spotlight section devoted to molecular and functional imaging. This is probably different from what many people are used to, where you think of imaging as something like a mammogram or a CT scan, and you're looking at structures and you're looking for abnormal shape and density. In functional molecular imaging, you're actually imaging in many ways the in vivo biology of the tumor. And you're looking at features such as its blood flow and perfusion, for example, by MRI. And you're also looking at its molecular features such as glucose consumption, the expression of targets such as ER, estrogen receptor, and HER2. And so it's a technique that is not so much about looking for structures, but looking for in vivo biology and biochemistry. What's really exciting here is you can identify potential therapeutic targets and make decisions based upon the full burden of, for example, metastatic disease rather than just a single site that you biopsied. And these techniques also allow you to be able to measure response, not only later, but in some cases relatively early, sometimes within a week or two of starting the response. And the reason I think that's important is we have so many choices for breast cancer treatment. We're fortunate that way. If we pick a treatment and it happens not to be the right treatment, and we figure that out at 2 or 3 weeks rather than 2 or 3 months or 2 or 3 years, hopefully not, then we can do a much better job of getting the patient to the most effective treatment as early as we can. For these molecular imaging techniques, we're sometimes looking at a different population of patients than other techniques do that are looking for early detection, early staging. We can actually be most effective in those patients that have a higher burden of disease, many of whom are getting probably more systemic therapy than local therapy, and we're understanding how that disease may vary from site to site, how it responds to therapy, where we can see biochemical changes before we can see anatomic changes. Our sweet spot is in that locally advanced and metastatic breast cancer group. I want to make a point about the ability to use molecular imaging to make an early assessment of response. Number one, if the treatment is not the right treatment and not working, and you can find that out in 3 weeks rather than 3 months, that's great. The other thing is, in many cases, people are nervous about having the disease progress, and knowing as early as 3 or 4 weeks that you're at least not resistant at that point, and can come back to that over the course of treatment, gives oncologists a new tool to allow them to continue effective treatments, even if it's not eradicating the cancer, but at least controlling its growth before having to switch. And with metastatic breast cancer, it's a long game. You want to use every treatment that's effective as long as you can. And these tools not only tell you which ones aren't effective early on, but can really give people confidence to know how long to use a treatment and perhaps when to switch. I do want to encourage patients, and I've worked with so many generous breast cancer patients that have given their time, is we develop these new imaging agents and tests. We've got to validate them before we can use them clinically. Those people that did this for us 10, 15 years ago have now led to treatments that we're using in the clinic. So as you think about therapeutic trials, also think about the diagnostic trials that might go with that, because that's a huge benefit to the field that really comes back and especially helps metastatic breast cancer, and for which imaging researchers like I am entirely and will always be grateful. I do want to emphasize that some people are worried when they take some of these radiology tests that they're getting a lot of radiation and it's building up. We don't go out on the street and wear signs encouraging the public just to come in and do these tests if they don't have a cancer. But for women in metastatic breast cancer, the amount of radiation that's coming from these tests is often less than what you would get with a standard CT. And in the grand scheme of all of the different things you're getting to treat the breast cancer, the chance that a diagnostic PET scan or something of that sort is going to do harm to you is quite negligible. In many ways, I think sometimes the metastatic patients feel a little bit left out of the equation for these new therapies. And our hope is that using these tools to not only identify targets, but have responses to enable much wider choices for patients with metastatic breast cancer, and much more wide open access to trials now that we have ways of measuring response.